Thanks everyone for joining us tonight. Tonight, Dr. Donnell Sequea will be our speaker for the evening. Dr. Sequea is board certified in both physical medicine and rehabilitation and pain medicine. He specializes in non-surgical management of the spine and musculoskeletal disorders, including the cervical spine, which is what he will be presenting on tonight. Dr. Sequea sees patients at our Doylestown, Willow Grove, and Bluebell offices. If you have questions throughout the presentation, please feel free to enter them. There's a Q&A box at the bottom of your screen, and Dr. Sequea will take some time at the end to get those answered. Go ahead, Dr. Sequea.
All right, thanks, Natalie, for that introduction. And for everyone that's logged on, thanks so much for taking the time out and just chatting with me today. I wanted to just have an opportunity to discuss, this common problem of low back pain, and especially with a lot of patients out there having this issue, just being able to take some time just to kind of discuss it from, my point of view, and just from a physician point of view, and equally to get feedback from you all out there, with back pain, or if you know friends and family that have back pain, and really just making myself available to answer any questions that might be coming up from time to time. And especially I know clinic visits can be kind of fast paced, and there's not a lot of time to kind of discuss things, and so hopefully we've reserved 45 minutes to an hour to do so today. I have slides prepared mainly to provide some structure, so I'll go through those slides here. But certainly, if any questions come up, feel free to send them through the chat feature. I think there's a raise hand feature if there's any burning questions. And again, not only questions, but I like to kind of hear feedback and experiences, things that you've experienced in the past that you found helpful, that I'd love to learn about too. So please feel free to share. Please feel free to share. First, just a little bit of background personally with me. I grew up in the Maryland area. I went to University of Maryland, Baltimore County through undergrad, and then went out to Michigan for my med school training. And then I came back for a year at Maryland for my first year training for my prelim. And so I definitely have roots in this area, in the East Coast, in the Maryland area. Then I went out to Chicago. Did a fellow residency there in physical medicine and rehabilitation, like Natalie mentioned, and then went to it was the Rehabilitation Institute of Chicago, and then they changed the name to Shirley Ryan Abilia, but a very comprehensive and robust training program there, so I was very lucky and fortunate. And then I went back to the University of Michigan for my fellowship in pain. Spent some time in the Pacific Northwest, and then I met my wife at Northwestern. We're both physiatrists, actually, and so after practicing in the Pacific Northwest, we came to Bucks County, Bucksmont area, where my wife grew up in Doylestown. So that's kind of what led me here at Rothman, and very fortunate to be here. So starting with just a little bit of background, back injuries, the punchline here is that they're pretty common. So you can see here about 85% of the US population will experience some level of back pain. But the good news is, majority of people improve. And that's independent of any type of treatment. So that's good news in general. And a lot of times when I see patients, I'm providing a lot of reassurance that, things typically get better, especially for those acute muscle injuries. It's not unusual to have recurrent episodes, and we'll kind of talk about some of the things that we use to treat for certain aspects of back pain. Before I get into some of the epidemiology, the whole demystifying back pain, the reason why I titled it the talk that is, a lot of it is trying to figure out the question of why, why you're having the back pain. And one of the goals of the physician too is to try to figure out the pain generator, to really figure out, what can we offer, what can we do? And a lot of the times, if we figure out the actual pain generator, then that can kind of help, come up with a very specific treatment for this particular source of the back pain. So, obviously, back pain can be pretty severe. There's a burden, financial burden associated with missing work. You can see here, upwards to 60–70% of people, even though they miss work, they typically can return to work within 6 weeks. And this is sort of all types of back pain. And then you can see the majority, definitely within 3 months, can typically return to work, depending on, what they do. You can see here, 10–20% can become chronic. And this is the population that I often see in the clinic, when things kind of go on for several months, maybe even years. And so at this point, then we're really, kind of visiting the doctors and trying to figure out exactly, again, can we figure out what that pain generator is? This is a slide here that shows the confounding factors for chronic low back pain. So you can see here, starting at the top, psychology factors or psych factors. So we know that, stress, anxiety, depression, or mood can have a negative effect on low back pain. So I like to, when I talk to patients, whether it's the initial visit or follow-up, just kind of get an idea of, how things are going in life. Are they stressed? Is there any kind of other like burdens or, like mood issues? Because, sometimes that can affect, how we approach treatment for back pain as well. Obesity, actually unclear. We like to think, especially for like the joints and the lower extremities, like the knees, obesity has a negative predictor with respect to pain. But in the back, it's unclear, the precise association with obesity. Obviously, I do preach, maintaining healthy weight, just because of the abundance of other positive benefits. But as far as back pain specifically, no clear association. Posture, whether it's LLD stands for limb length discrepancy or lordosis, no specific association, but general posture is something that I like to put in my physical therapy scripts to help with reducing day-to-day back pain and coming up with corrective measures to help reduce pain associated with not only low back pain, but also neck pain as well. So this is the big one here. So generally age, right? So the higher the age group, the higher typically you have findings of back pain and reasons for why people develop chronic low back pain. Smoking, a big one as far as, counseling patients to, stop smoking or find ways to curb smoking, because this one, there's a very strong association with low back pain and sciatica. Sedentary work, increased with driving, prolonged sitting, physical work, increased with bending, twisting, heavy labor. So, we don't have a lot of choice sometimes what we do with work, but, if I can go over some of these risk factors and try to figure out, what types of requirements people have at work, then sometimes I can counter that with either a specific physical therapy script or through counseling, or, even in the acute sense, maybe putting in some restrictions to kind of help with recovery of back pain. So again, just general things that I consider when we're kind of talking about back pain in general. And then this last one is just, why we stress physical fitness and physical therapy, because there's a decreased risk with core strength. In this case, holding a plank. And so you can kind of test it out yourself, if you go home today and go on the living room floor and just getting a plank position and kind of see how long you can hold that position without too much shaking or pain. That usually has a good correspondence with, reducing the risk of developing chronic back pain. So this is, kind of a summary slide. I like this slide because it kind of shows all the different sort of like facets of low back pain. And so this slide really gets to that, figured out the pain generator, right? So starting with this area here, radicular pain, this is a very special subset of axial back pain. So radicular pain, some people, say sciatica or pain in the legs. So this type of pain comes from the back, and it really implicates the nerves in the back, right? So very commonly it's associated with herniated disc, classic association with, getting a cold, having a lot of coughing, a lot of sneezing, causing a lot of, pressure developing in the spine, and it can cause herniated disc, thus causing pain going down the leg. So this is the one that I screen for all the time when I see patients with back pain. I really want to make sure that there's no nerve involvement. There's a very, and I'll go over that a little bit, there's a very specific treatment paradigm that we take with radicular pain. I'll take you through that a little later in the presentation. You can see here are all different areas or pain generators that are associated with axial back pain. So, oops, I'm doing something to my screen here. So on the top is sort of the muscle layer or myofascial layer. So that's where your muscle spasm comes in, your acute back pain, very common. The good thing with acute back pain in the muscle is that it tends to come on fast and it goes away fast. So this is where that reassurance comes in with a lot of patients who come in with muscle back pain, that, 90–95% of people get better. There is a certain subset of patients that have pain just below, the muscles of the back, and it involves this joint called the sacroiliac joint. So this is another screen that I typically do in the clinic to try to identify, is pain coming from a certain pain generator. And again, I'll have some slides dedicated to sacroiliac joint pain. So I'll have a little more detail on this one, but again, very specific exam maneuvers, and there's a different treatment paradigm for SI joint pain compared to muscle pain compared to radicular pain. Just some other aspects of back pain. So the facet joint, a lot of you might have been told that you have facet arthritis, or the pain is coming from the facets. So this type of pain tends to be purely axial. And so the axial back pain, in contrast to the radicular pain, typically doesn't have a leg component. It's usually right in the blowback. It doesn't seem to spread too much. And this is the pain that can tend to be a little hard to nail down at times. And this is what I work hard to try to provide patients with some insight of, exactly where is that pain coming from? Is it coming from the muscle? Is it coming from the SI joint? Is it coming from the facet joint? And I'll show some examples of the facet joint as well. I believe I have some pictures that I'll be able to show you. And usually, when we get to the point of getting x-rays or MRIs, I'll point out all of these different pain generators to my patients to try to get an idea of, what these different areas of the back look like, and then combine that with physical exam to see if, those areas might be a source of pain for them. And then the last sort of circle here is just an intervertebral disc. So sometimes you can have a disc issue that doesn't cause the radicular pain or the leg pain, but it can cause some back pain. And so, that can also be treated in similar ways to radicular pain, but it just takes some special considerations. Actually, let me go back because I think I forgot one here. So spinal stenosis, I think we have a question about spinal stenosis. So spinal stenosis is, it's a little different than the radicular pain. So radicular pain, usually there's one single nerve root that gets pinched by, let's say, a herniated disc. Spinal stenosis is when that central canal gets so narrowed with an accumulation of chronic disc herniations and arthritis, maybe in those facet joints, that it causes the canal where those nerves come through to be pinched. And so it kind of it surrounds multiple nerve roots, and so you get this phenomenon called neurogenic claudication, and typically that occurs with walking. And so the classic situation is, they call it a shopping cart sign. So you're walking in the grocery store and you're having to bend over and lean on the cart, try to open up the space in the back to try to relieve some of that pain going down the leg. And maybe if you're walking in a decline down to maybe check the mailbox, you might find that you have some pain down the legs. But as soon as you stop, as soon as you rest, that pain gets better. That's classic neurogenic claudication. So that's another aspect that I like to identify in my patients. And you can see the distribution of patients are typically over 65, as opposed to like a disc issue, which is longer than 45. So sometimes the age of the patient can kind of clue us in on what's going on. All right, so I just like to put a little basic anatomy in here, kind of get an idea. A lot of you have probably seen, some of these pictures and have seen your own images, and so you're vaguely familiar. But for those who, again, kind of trying to demystify the back pain, it's important to know what how the back is composed. So in general, most people have 5 lumbar vertebrae in the low back, and so they're numbered L1 through L5, right? There are some exceptions. Some people, may have been told they have a 6th vertebrae. That is sometimes an anatomic phenomenon that can occur. So this is some specific anatomy here. So, the nerve roots travel under the pedicle. So I believe you guys can see my arrow. If not, you can let me know. But on the right side of the cartoon, you see one vertebrae here labeled L4, and then below it, it's labeled L5. And so the nerve roots run under those holes, which are called the foramen. So you can see here that the L4 nerve will exit here, and then the L5 nerve will exit through the foramen of the L5 vertebrae. So when you come in and I examine you, if you're having leg pain, I like to figure out, is there a particular pattern? So is it an L5 versus an L4 versus an L3? And that's even before getting an MRI. And then once we get the MRI, then we can, kind of correspond the imaging to your anatomy. And, if it all lines up, then we feel better about, our confidence with giving you a particular diagnosis. Again, these are sort of the scientific words for the component of the gel or the disc in the back. And this nucleus pulposus is sometimes what we call the jelly, if you will, in the middle. And so I think I have a better picture here that's blown up. So you can see here that jelly material is in the middle. That fibrous tissue surrounds the disc. And what happens is you get a little wear and tear, and you get a weak point, and that gel-like material migrates out and it hits the nerves. And so here's the nerves here, and those nerves as they exit out to go to the legs, and that's why you get the leg pain with disc issues and that particular lumbar radicular pain. And so if I go back, you can see here's that cartoon showing that disc material coming out. And so if you've ever been told you had a disc herniation, this is what's going on in the back. While I'm here, I'll have the opportunity to point out. So here are the facet joints. So those are those joints in the back that I said that can get prone to arthritis. And so you can imagine if the disc pushes back on the nerve, that if you get a lot of arthritis and a lot of buildup here, then that can push forward into the nerve as well. So again, just a little bit of anatomy to try to understand how we identify what pain generator, based on, again, this chart showing the different possible pain generators. All right. This is just a little nomenclature. It might be a little specific information, but I usually tell patients when I'm in their clinic, sometimes, we find things on exam, weakness or reflexes down, but many of the times we don't. Sometimes people have what I call normal exams or non-focal exams. And so instead of a radiculopathy, meaning that there's some sort of injury to the nerve, some people have a radiculitis. And that doesn't mean their pain is made up or not, from a nerve issue. It just means that nerve might be irritated and not causing any damage. So in a way, that's good. But as long as pain's coming down the leg, even with a normal exam, I'll still give them the diagnosis of a radiculitis or a pinched nerve, if you will, in sort of a layman's term. All right, so just some of the things that I like to discuss with patients. What's the onset? Is it gradual? Has it been going on for a long time? Is it worse with coughing? Is it worse with sneezing? Forward bending with the load. I'll show a very classic study that shows why forward bending with a load is bad for your back. Is it sharp? Is it burning? All these things clue us in when we're trying to make a diagnosis of a specific pain generator. A physical exam is very important. Is it one nerve? Is it multiple nerves? Is it a claudication picture or is it a single radiculopathy picture? All right, so in every visit that I see for back pain, we want to make sure it's not an emergency. These are things that are not necessarily treated appropriately in the clinic. But these are reasons why you might want to go to an emergency room. Something that most pain physicians or back physicians, even primary care physicians, are pretty aware of, and they will likely screen for, is this cauda equina syndrome. And so it's characterized by bilateral or single extremity pain, weakness in the legs, groin numbness, and then it's typically urinary retention or like trouble emptying. So, incontinence is, we ask about incontinence, but typically it's urinary retention. And so if, anyone is experiencing any of these symptoms, then that's, something that we recommend going to the emergency room for. Obviously, if I ever find like a malignancy or mass effect, not necessarily emergency room, but we're probably looking at a pretty urgent referral to a surgeon or a cancer doctor. The weakness, it's one that I can't evaluate in the clinic. Not all weakness is an automatic emergency. So if you're experiencing weakness, it's something that I screen for all the time in any case of back pain. And so if I find that a patient is weak, there are things that I can do to help treat it. If it's something that we're worried about, we may get a nerve test or refer them to a surgeon. But that's sort of where the nuance of the clinical exam and the visit, we can kind of discuss that mutually. So just some things that are usually at the top of the list as far as figuring out. My exam, again, we don't have to really get into the details of the words, but these are things that I'm looking for on exams. So facet loading, is it the facets? Are you having any hip hiking, foot slaps? These are all terms that suggest maybe there's some weakness of a specific nerve in the back. Are there any like tension on the nerves that cause pain? So that kind of triggers, this might be a radicular pain. And then there's particular reflexes that are down, is it an L4 versus S1, that sort of thing. So these are all going into the evaluation, but like I said, when you're there in the clinic, things are moving very fast. Sometimes all these details are not explained to patients, and they're kind of just going through the motion. And I've been doing this a long time, well, 3 years, long time, but the exams are going by pretty fast, and so I'm doing a lot, in my mind, but sometimes, patients may not, appreciate that there's a lot going on in those initial, 5-10 minutes. Again, a lot of different tests here. So these are just sort of things you might see if you ever get copies of your, physical exam. You ever look through, you may see a lot of these words and a lot of these names, and these are just, again, things that we use, tools in the exam to try to figure out, what's that pain generator. Yeah, again, I kind of talked about this, so kind of skip this. So I wanted to come back to that sacroiliac joint pain. So this is a very another common source of pain for people. There is a joint that connects the bottom of the sacrum to the hip, and I call it the great mimicker, because SI joint pain can mimic facet pain, it can mimic muscle back pain, it can mimic nerve pain. So if you look at this cartoon in the middle, you can see that the red areas are reflective of the pain pattern, excuse me. And so you can see that it can mimic back pain, it can mimic buttock pain, it can mimic nerve pain coming down the leg, even as far as the ankles and calves. And if you notice here, this is a front-facing cartoon. It can actually mimic groin pain, which we usually consider hip pain. So this is one that I typically would screen for as well. And like I said, there's a very specific paradigm for SI joint pain through physical therapy, and there's specific injections that I do for SI joints that are very different than, let's say, a radicular pain or a sciatica versus a facet-mediated pain. So this is just an idea of some of the exams that I do, and so some of you, may find that some of these maneuvers look familiar. And again, it's all in that effort to try to find the pain generator, so that we're giving patients a specific diagnosis and giving them a specific treatment of their back pain. All right, so diagnosis, or sorry, imaging. So this is a big one. So all cases of back pain, doesn't need imaging. Right. So I usually follow a pretty specific criteria of when to get imaging. So you can see here in general, imaging usually is ordered when there's no response to 3 to 4 weeks of conservative therapy. So if someone comes in with back pain, it's been only going on for 5 days, 10 days, it's typically muscle pain, and there's no more information that I'll get from ordering an X-ray and MRI at that point in time. And it doesn't mean that the pain is not intense. I mean, I've gotten 10 out of 10 pain that's been going on for like 7 or 10 days. And it doesn't mean that there's anything structurally wrong in the back. And so by following a criteria similar to this, usually we can, kind of decide who needs imaging, when we need imaging. And so if we look down the list here, so in addition to no response, if there's any severe or progressive neurological deficits, then I'm definitely getting imaging. If there are any of those red flags that we talked about, I'm definitely getting imaging. Patients with radiculopathy, especially those with abnormal exam findings, for the most part, I'm getting MRI for their back. Some people can't get MRI, so sometimes CT imaging is used. And again, the imagings are overwhelmingly used prior to any surgery indications or any epidural or steroid injections. Again, most people we would get MRIs for those patients who have pacemakers. Then we may order a CT, but both imaging modalities are useful when trying to make a diagnosis for, let's say, a herniated disc or spinal stenosis. Providing reassurance. So we talked about providing reassurance for patients, when they come in with back pain, 90% of people get better. But also with people who have imaging, you can find a lot of quote unquote abnormal findings that is questionable how significant they are. So up to a third of people, if they have no pain, I take 100 people off the street and I MRI their back, I will find findings of disc bulges, facet arthropathy or arthritis, and they're totally asymptomatic, no back pain. So we have to be careful with what we see on the MRI, and that's why we take so much time with the history and the physical, because we want to be very specific with corresponding that to the MRI imaging and making a specific connection to give you a diagnosis. And sort of in a similar vein, you can see, if you take a cohort of patients from 20 to 40, 20% will have herniated disc, 56% will have disc bulges. And then as we go up the age demographic, now 40 to 60, you can see disc degeneration goes up a little bit. And then when we go to that over 65 crowd or over 60 crowd, then we're starting to see more herniated disc, more disc degeneration, and even spinal stenosis. So this is just to make the point that just because we see it on MRIs doesn't mean that patients need surgery or they need any kind of acute intervention. Sometimes it's just sort of trying to rewind the clock to get them back to a place where they're asymptomatic. EMG, NSC, this stands for electromyography, and NSC stands for nerve conduction study. So this is the, some of you may have experienced this. It's not the most sensitive test. Oh, sorry, it's not the most easiest test to conduct because it involves shocks and it involves needles. And so we don't get this all the time, but sometimes your physician may order these to tell between a issue coming from your back versus an issue in the peripheral nerves. So it has its place, and it can localize a lesion, but again, a lot of the times we can come up with a diagnosis, especially with a nerve issue, without getting any EMGs or nerve conduction studies, but very useful in a very specific setting. So prognosis, like I said, improvement in pain and function is expected in about 4 weeks, especially for the radicular nerve pain. If you follow up patients at 3 and 12 months, a third of people can still have pain. And in subset of patients, sometimes surgery is sometimes needed for those populations, but it's the minority of patients. So I'll have a slide of when I refer to surgery, because there is a place for surgery sometimes, but like I said, the majority of patients do get better. And here again, just sort of more studies that have shown that, most patients get better. So again, even, you can be going through the most excruciating pain in, a week, 2 weeks, 3 weeks, but, after about 4 to 5 weeks, especially with treatment, that pain typically gets better. This is just a slide here, just sort of getting into the treatment with physical therapy. So physical therapy and physical activity is the first line and the best treatment for back pain and all the other manifestations of back pain and leg pain. In general, bed rest is not what you want to do. It makes the muscles weaker. It can cause, leg pain to worsen. It can cause nerve pain to worsen. And so in general, stay active advice is the way to go. So you kind of do what you can. Physical activity is tolerated, but you definitely don't want to wrest back pain away. So before I get into the physical therapy, there's a lot of things that you can do, heat, massage, spinal manipulation, which, can be from a physical therapist, a massage therapist. Sometimes you might see a doctor of osteopathic medicine, a chiropractor. There are sort of evidence to suggest that you can get modest improvements in pain and function with some of these non-pharmacological therapies for low back pain. Self-care exercises, now we're in the internet age where you can look up, exercises for your back strengthening. You can look up YouTube videos, things like commercial, like Peloton, they have a lot of like videos, yoga. So there's a lot of resources out there. Sometimes, you need some context, but there is a lot out there to try to help with treating some of these issues of or incidences of back pain. I put a little note here about acupuncture, or a reminder just to say, acupuncture has low to medium evidence for improving chronic low back pain, and for some people it can be extremely beneficial. So just a little plug for some of these other modalities that some patients find to be very helpful. Physical therapy, very important. Like I said, there's the education piece. So going over biomechanics of standing, lifting, sitting can be very helpful for back pain. Core, lumbar stabilization, here plus or minus manual therapy. Sometimes the hands-on aspects of physical therapy can be very helpful. So in my prescriptions, I typically are very detailed about that. So here's a very classic study that we go over as far as physiatrists and training. So it has to do with posture education and physical therapy exercises, right? So if you focus on the left panel, so when we reviewed these studies, apparently, in the 70s, they did sort of these experiments using medical students of all people. And so they were actually measuring the disc pressure in the back. And so if we call our baseline 100, which is just standing at attention, you can see when you're recumbent or lying down, the pressure in the disc goes down, right? So that's what these numbers mean here. But you can see the situations where the disc pressure goes up. So the higher these numbers, like this 275, you're increasing the pressure through the disc, which in turn increases the the risk of disc herniation. So I usually counsel my patients that you don't want to be in this position. So sitting, flexed over, with any type of weight in your hand, because that puts a lot of pressure in the disc. And you can say, even if you take away pressure, you're still having a lot of pressure in the disc. So, for people who are active in the gym, you want to be careful with weights and those sorts of things. This is another panel here, kind of a similar process where they're measuring the disc pressure, but this has to do with home versus PT exercises. So, a lot of people, don't like, going to physical therapy. It's a time sink. You have to, schedule a time. It takes away time from work, busy day-to-day activities. But you can see there's an advantage of going to physical therapy with having an instructor helping you. So if you see that this person here in the cartoon is doing home exercises, but you can see the relative pressure in the disc that can happen. So some patients may actually have increased pain when trying to do these self-care exercises. So in those situations, I usually recommend having some sort of assistance. And so the best way in my mind is, going with a physical therapist to try to help offload some of that pressure in the back. And then here's some of the exercises that I hand out to patients to try at home, and and probably the physical therapist. And a lot of these exercises probably look very familiar as well. McKenzie physical therapy is a very specific type of physical therapy that I oftentimes recommend to patients. So, if it's something that if you're very savvy with online, you can look up McKenzie, and if you're very savvy, I don't make any money off these books, but McKenzie has a series of treat your own back kind of helpful exercises that sometimes can be helpful. I'll skip through that. So this is just an example of a physical therapy prescription that I may send to your physical therapist. Are there any precautions? Weight bearing is tolerated. The frequency of visits, 1 or 2 times a week for 4 to 6 weeks. Some of the things that we like to focus on, modalities are okay. Can the patient benefit from some manual therapy? Where are we targeting? That sort of thing. Are we doing any gait analysis? Some people can't tolerate land. So should we, introduce some pool therapy? So these are all things that kind of go through my evaluation for back pain. And again, this is just sort of, belaboring the point, but again, most people get better. 92% outcome after 31 weeks. Seems like a long time, but it sometimes can take a little bit of a grind to get rid of some of these different pain generators that we come up with. This is an important slide that sometimes I like to point out with patients who get MRIs. So the patient on your right is a control, and so what you're looking at is an axial view of an MRI. Excuse me. So this is the central canal here. So remember I talked about something called spinal stenosis. So in the middle of the spine, sometimes you can get a little bit of spinal stenosis where that disc pushes in from the front side, and that facet joint pushes in from the back side. And instead of getting a nice circle, you get this triangular shape, which can cause that neurogenic claudication. So I just wanted to point that out since I mentioned it earlier. But if you look here, these are the back muscles. So this is, what we're trying to strengthen when we send patients to physical therapy. And what can happen if you don't spend time strengthening the back, you can get this muscle atrophy. Excuse the typo there. It's supposed to be muscle atrophy. So you can get these white streaks, and that's fat infiltration. So this is the natural fat layer, but we don't really expect fat in this layer. And so sometimes you can get fat infiltration there. And as we age, what happens is the muscle, which are a postural or structural function, or provide a structural function, they start to weaken. And that's when we get pain from these areas, the facet joints, the disc, and the spinal stenosis. So just something that sometimes you can point out from time to time through the MRI imaging for patients. Here's just a list of treatments in the terms of medications. A lot of these look pretty familiar, and when I see patients, I go over medication. Sometimes these are not always available to patients due to side effects, or maybe they're on other medications, so they can't take NSAIDs, or if they have kidney dysfunction. So part of my evaluation kind of goes over a lot of these things. We're kind of getting toward the end, so I definitely want to leave some room for questions, but here's the epidural steroid injections that we use to try to help with nerve pain. The punchline is there's various approaches, but it is effective, and so I use injections as part of my practice to try to help reduce pain. But remember that the idea is to reduce pain to try to send patients back to physical therapy. Just going to kind of go through this a little fast here, but this is sort of an example of what the injections look like. They're pretty straightforward, but all procedures have risks, so we will usually spend some time talking about the risks of the procedures. But for the most part, for most people, they're relatively straightforward and low risk procedures to help with pain. So surgery, like I said, a subset of patients do, need surgery. There are basically two big categories of surgery. So there's decompression, which means we're opening up that space, or decompression infusion. And so when you see a surgeon, usually they can talk about the nuances of these two things, but in general, these are the biggest two approaches to a surgery for the back. When do I refer to surgery? When I've exhausted all the things I just talked about for about 45 minutes. Radicular pain symptoms after maximizing conservative treatment, all these things, urgent situations, those red flag situations, I'll refer to surgery, or maybe a severe or progressive motor deficit. And there's a special consideration myelopathy that I look for when I screen patients. I'll stop there. I think I probably went through more of the slides than I thought I would. Hopefully you got a little bit of my approach. I usually basically that 45 minutes, that's what I'm doing in about 10 minutes to 15 minutes in a patient encounter for every patient, and all those considerations are kind of flowing through my mind. So I just wanted to take the time to spend the 45 minutes to an hour we had today to try to just again give you some transparency of what we're thinking about as we approach a patient's back pain. So with that, I thank you for your attention, and I'll be happy to take any questions or comments. It looks like we have a few here in the Q&A. So starting with the top, so the first question I have here is, can injections help to alleviate low back pain caused by stenosis? And the short answer is yes. In general, my view is that the injections for the radicular pain or the pinched nerves work a little bit better. But we do injections for lumbar stenosis and neurogenic claudication, particularly the leg component. So I will offer that to patients who who fail physical therapy. There is another question here. Can you mention any possible dangers with chiropractic therapy versus PT? So obviously, chiropractors, sometimes, in the media or some of the, literature, you've heard of, some dangers with, vessel injury, especially in the cervical spine. So I usually recommend to patients to, develop a relationship with your chiropractor. And, I've known chiropractors that do wonderful work for back pain. And so, they're very diligent with doing exercises. They do, very careful manipulations. They look at x-rays. And so, I don't think they're inherently dangerous. Certainly, if I evaluate a patient and I find that there's any abnormal findings on exam, if there's any issues with nerves, then I may tell a patient, maybe we hold off from PT or maybe not go to the chiropractor until I, think that your exam is a little bit more stable. Or certainly if I think a patient needs surgery, I would say, hold off from chiropractic treatment. So I think it's situational, whether, there are any particular dangers with any of those therapies. And I think it's going to come on to a discussion with your physician, to determine, how safe those therapies are. So inversion therapy. So inversion therapy is similar to the chiropractic treatments, right? So I think it's something that you can try if you find that it's helpful. The idea with inversion therapy is trying to provide some, distraction to the back to try to help those nerves breathe a little bit more. It works a little bit better in the cervical spine, but traction therapy. But I've had discussions with patients who say that inversion therapy is can be helpful. It's something that there might be an expense associated with it, so you may want to try it out in a physical therapy office first before kind of committing to the expense of setting up your home system. Next question just says the thoughts on nerve blocks. So the nerve blocks, it depends what you mean by nerve blocks. So my epidurals, on some of them, I use a local anesthetic, and that can be considered a nerve block. I do injections for facet joints, and sometimes that involves nerve blocks. To me, my definition of nerve blocks it's a temporary thing for a diagnostic value. So, so I think that's probably a very specific conversation depending on what is indicated based on, again, the pain generator, on whether you have a particular nerve block. But in general, I use them all the time in my practice. Next question is, how many injections can you have? And so that is, I like to be as specific as possible. So if I can get away with one level, one injection, I'll do that. If there's, two nerves involved, then I may be a 2-level. Very rarely do I do bilateral injections, just because, if I make one leg weak from the injection, then I don't want to make both legs weak. So there's some consideration as far as planning the study, and that involves talking to you as the patient, looking at the imaging and figuring out how much nerve involvement there is. But in general, I like to be as specific as possible. But I have done 2-level injections or bilateral injections before. There's a patient about morning stiffness lasting about 30 minutes. So with a family history of arthritis. That is a very specific, when I hear that type of story, the first thing I do for my patients is talk about systemic or arthropathy pain related to some kind of rheumatoid disorder. Usually what I talked about was degenerative pain. And so when you have degenerative pain, it's very specific. It's usually one area. It's the back. It's a one nerve going down the leg. When you have pain, that's generalized stiffness, pain in the knees, the shoulders, the back, I like to rule out some sort of like rheumatology pain generator. So what I do is I get labs, inflammatory labs, and I rule that out, and then we can kind of unpeel some of the other pain generators to try to understand the arthritis. But so yeah, so that's probably something that I'd see you for in clinic. There's a question about how many steroid shots can a patient get in a year? Typically, it's between 3 or 4, and that's to prevent any sort of adrenal or pituitary axis side effects with the steroid. So I usually limit 3 to 4 a year for my patients. Another question here, what is the best way to self-evaluate pain in terms of severity before reaching out to a specialist? So everyone has that different number. So I still ask patients, what's your pain, 1 to 10? Some patients, say 10, some patients say 1, and, maybe they have the same exact, ailment. So I usually say, pay attention to your gut. What's your gut telling you? Are you worried? If you're worried, then I think it's worth coming in and talking to a specialist. I have no problem talking to a patient and saying, you know what, everything I see looks good, your exam looks good, and providing reassurance and confidence. Or in the event that I find something, we can talk about that. But I would say the best way is to listen to your gut, especially if pain is interfering with daily activity. Then that's probably a reason to reach out to a specialist. I think this was a continuation of the other one. I mentioned SI joint nerve ablation side effects. Yeah, I didn't mention that specifically. The SI joint nerve ablation is related to the radiofrequency ablation therapy. It can be effective. Unfortunately, that's something that insurance companies, may not approve. And so that specific procedure would require a discussion regarding, insurance and payers. And, so it might be a little bit more than answering it very quickly. But in general, the SI joint nerve ablation has been received with mixed, excitement in the spine and pain world. Next question. Let's see. I'm kind of decipher 3. It's kind of more, again, like a story. So yeah, so no specific question there, but I would say, if you're having back pain and whether it's not sharp, but you're having any kind of question about it, I'd be happy to see you or one of my colleagues here at Rothman for sure. So certainly be something that would be worth a follow-up discussion. The next question has to do with laser therapy. I'm not very familiar with laser therapy. It has something that's usually more in the modality world, either a physical therapist or a chiropractor. I usually use the rule, try it 3 times if it works. If it's breaking the pockets, if it's kind of expensive and you're kind of using it over and over again, then it's probably not something that I would continue. But if it works and you perceive value, laser therapy, typically doesn't have a lot of negative side effects. And then the next question, just says lumbar paraspinal muscular atrophy. And that just has to do with the muscles along the spine, just to clarify. So that picture that I showed just shows that, if you don't use those muscles, you don't exercise those muscles, with age, you can get fatty infiltration and can cause other pain generators to come out. So it's something that I like to pay attention to, either on an MRI or even evaluating a patient in clinic, and can be benefited using physical therapy. Let's see the couple more here. Under chiropractic, is there a meaningful benefit of trigger point? I use trigger points. Trigger points are very specific in the muscle. So yeah, the short answer is there is a meaningful benefit to trigger points, and whether you get it in my office or a chiropractor office, I think there is a role for trigger points. I think the next question is, have I seen COVID infection causing increased back pain? The short answer is not directly, but I've seen this thing where COVID, closed all the gyms and, people weren't going out and exercising. So, what happens? Back pain goes up because, people are becoming more sedentary, they're not moving as much. And what happens is a lot of those pain generators become a smash. So indirectly, I think there has been, probably a little bit of a spike in back pain complaints due to COVID. And I'll make this my last question here. And the question, it's a surgery question. It's what is the difference between a microdiscectomy and laminectomy? So essentially, that just has to do with what tissues are being acted on. So like I said, both discectomy and laminectomy refer to decompression. And so it just depends on what the surgeon is taking out. So are they taking out the lamina? Are they taking out the disc? That will determine, what is it, a discectomy or a laminectomy or prostatectomy? So just a little bit of a technical question. Got one here. All right, so someone's scheduled for a lumbar interbody fusion. Epidurals did not work. Yeah, like I said, sometimes that happens. Like I said, surgery shouldn't be the first step. But if you've gone through physical therapy, you've gone through medications, you've gone through epidurals, and you're still having pain, then there is a role for surgery. And so without being familiar with your specific case, I'd say my general opinion is that that may be indicated for you, given the treatments that you've done before. Well, like I said, I'll close it here. We got another meeting after this, but again, I just want to thank you for your attention. And then certainly, if everybody wanted to follow up more formally, certainly reach out to our host and Rothman, and I'd be happy to see you. And Natalie, you can maybe provide a number to reach out. But again, thanks again for your attention and thoughtful questions. Very good session.
Thank you, Dr. Sequea, and thanks everyone for joining this evening. Yes, so we did record this. We will be sending it out to everyone who attended and everyone who actually registered. So if anyone had to jump off, they will see the entire thing. You all have my email. Since I was the host of this webinar, you have my email. Please feel free to reach out if you have any further questions for Dr. Sequea. If you're interested in scheduling an appointment, I am happy to help facilitate that. So thank you again. Thanks, Dr. Sequea. Everyone have a wonderful night.
All right. Good night.
Good night.